My name is Ulf Lindquist. I'm an orthopedic spine surgeon from Münster, and I would like to thank the Egyptian Spine Association for inviting us and allowing me to give this presentation on adolescent idiopathic scoliosis, and with special focus on the surgical techniques in stiff scoliotic curves. This is, as you all know, the standard of care in adolescent idiopathic scoliosis. We can either go from the front or from the back. And here are the x-rays. You can go anteriorly in single thoracic curves or even posteriorly, with some advantages for the anterior and other advantages for the posterior technique. We all know that in the anterior technique, the fusion length is shorter, the rotation is better, but the posterior technique is probably more easy, hasn't those approach-related problems, even though instrumentation levels might be 1 or 2 levels longer, especially distally. So in double major curves like the Lanky 3C curves, posterior correction of both curves is certainly absolutely the standard today. And in single labral curves, especially the Lanky 5 curves, the lumbar and thoracolumbar curves, the anterior correction, as you can see here from end to end vertebra, is standard of care and has clear advantages over the posterior correction. But these are standard cases, and I would like to focus on more challenging cases like these. Curves above 80 degree with a bending correction of less than 30%. As you can see here, 16-year-old girl with a 113 degree curve on traction reduces to only 108 degree. So what do you do with these challenging curves? Another example, 14-year-old girl with a 114 degree curve, and on the bending it reduces to only 70 degree. What do you do in lordotic curves, like here with a thoracic lordosis of 11 degrees and a very stiff curve? So these are the challenges I would like to discuss with you within the next couple of minutes. If we review the literature, the solutions in high degree idiopathic curves are either anterior release with posterior correction, a combined anterior and posterior instrumented correction and fusion, or even halo traction. We know that Pontier osteotomies are very effective. They allow a greater three-dimensional correction, they allow a better restoration of thoracic kyphosis, but also they increase the risk of neuromonitoring alerts. We have adopted following technique for more than 10 years ago and published that 4 years ago in the European Spine Journal. We do a single-stage pedicle screw instrument correction and fusion with a high pedicle screw density. We do thorough posterior release and a concave thoracoplasty to further release the posterior elements of the spine. So I would like just to briefly review the surgical steps. You do a slightly curved skin incision. You would do a thorough posterior release with the Schwab type 1 release. We do not do Pontier osteotomies for several reasons. We do the freehand pedicle screw instrumentation, as you can see here, with the high screw density and a full pedicle screw instrumentation on the concavity of the curve. And then we do a concave thoracoplasty, and that increases the flexibility by, well, 25 to 50%, and we lift the ribs onto the concave rod, and by that we also correct the chest wall deformity. We overbend the concave rod to restore kyphosis and underbend the convex rod. And the correction is done either with the reduction tools or with the reduction screws. That's really dependent on the system you use, but both is certainly equally possible. And then at the end of the surgery, some fine-tuning with segmental compression or distraction, and even some in situ bending. The correction we get by that is always in almost 70% curve correction. And here you can see our published numbers. Pre-op average angle was 95 degree, and we corrected down to below 30 degree. And we were certainly a bit better in the lumbar spine, which is obviously more flexible and wasn't that severely severe as compared to the thoracic curve. So we get 65 to 70% curve correction with that technique. Here, 2 or 3 examples. We have Teresa, 14 years old, with this 114-degree curve. We did this instrumented correction with concave thoracoplasty. And this is a 2-year post-op. Look at the nice shape of her back, the trunk symmetry, shoulders are leveled with a very nice correction down to 25 degree. And this is the postcard she sent me a couple of years ago with her, a proud girl doing vacation with his family at the beach. Another example, 13-year-old Lara with this severe curve, double major curve, with a severe rib hump. Post-instrument correction and fusion, 2 years post-op. Look at the nicely stretched trunk with the restoration of the chest symmetry, no rib hump anymore, with a nicely balanced spine. What to do in this very lordoscoliotic curves with even thoracic lordosis? Well, what we'll do here is we use the 6mm cobalt chrome rod, which is very hard to bend, I have to admit. But with these stiff and rigid rods, you will be able to create a kyphosis. As you can see here, this is an only posterior case, and we've gained kyphosis by almost 30 degrees. What about the lanky 6C curves? These, as you can see here, 90-degree thoracolumbar curve, very marked asymmetric waistlines. These are the curves where the posterior only is probably not suitable to achieve a good correction. So these are the one and the few curves where we still go front and back. So we start anteriorly and correct the thoracolumbar spine down to 11 degree and then do a posterior correction to take care of the thoracic curve. And here you can see the post-op results with nice symmetry of the waistlines and a leveled shoulders with a well-balanced spine. Finally, these are probably the most challenging curves. These omega-shaped curves, 140 degree. Sophia from Armenia came to see us with this severe curve. She had a severely restricted vital capacity. And these are the cases where I have to do a vertebral column resection in order to get some curve correction. And this is quite challenging surgery, very risky surgery. This is the way it works. You insert your pedicle screws and then you just resect the apex of the curve, and you have to be very careful with the spinal cord, which is at risk. So neuromonitoring is of course mandatory, and then you do the correction without shortening the spine too much. Here you see what we did. We did the apical vertebral column resection, T8, plus concave rib osteotomies, pedicle screw implantation, corrected it down to 60 degrees, which is a 60% curve correction. But look at how nicely stretched the trunk is with a balanced spine and level shoulders. And this, she gained 12 centimeters, was neurological, of course, intact, and she's very happy, as you can see here, with the result. So let's have a look into the literature. Only posterior correction and fusion in the high degree curves, 60 to 65% cop angle correction. These two papers investigated the role of the anterior release, and they compared a anterior release group with a posterior only in these high degree curves, and they found a very limited curve correction, to be honest. In the AP group, 37%, and the posterior group, 43%. But at least they conclude that the anterior release and traction had no effect on the curve correction, which I absolutely agree on. Another group published in 2012 compared anterior posterior with the posterior, and again found no effect of the anterior release. So I guess the anterior release does not play a role in treatment of these severe and rigid curves. Complications. Finally, we have to talk about complications. We know that in adult spinal deformity, at least if you do no osteotomies, the complication rate is 70%. If you do Smith-Peterson osteotomies or Ponti osteotomies, you will increase the complication rate to 30%. Pedicle subtraction osteotomy is 40%, and the posterior vertebral column resection is 60%. So in summary, to take care of these challenging cases, high degree rigid curves, you need a high and full screw density. careful selection of your osteotomies to balance the risk, and to release a certain a very limited effect. We have given up that more than 10 years ago. Rib osteotomies on the concave side are very effective, especially if you have a severe chest wall deformity, and of course neuromonitoring is mandatory. Thank you very much for your attention.